Yes.
Is there a window for families, or is it exactly on the 7th day?
There is, I understand, a 2-day dosing window, plus or minus 2 days, that is allowed. And more information on dosing windows or what if I miss a dose will be coming to you guys.
Is there a specific time period that they should be aiming for, like in the morning? Or?
I will ask my colleagues. No.
Yeah, we'll give you some guidance documents for that, but there's no preference of morning or evening. It's just within plus or minus 2 days of their normal scheduled day. And the other thing we'll give you is that the 2 doses cannot be within 5 days of each other as well, but they'll be given to you in a guidance document.
And one thing to highlight that I keep telling myself as well now that I'm looking at Kenny, so the dosing schedule is based on the date of the first dose, not the time since the last dose, right? So an example, so if you're dosing every Tuesday, you can go plus or minus 2 days, but not since the last dose. It's compared to the original schedule. We're always going back to the original first date of dosing.
But you have the 5-day. You can't dose within 5 days, so we have to go back to when the last dose was.
Yeah, you have to consider that, yes. But your schedule that you should try to stick to will always be based on first dose date. Although that is the date of last dose is a consideration. Okay.
Just a question.
Hi.
Just a question about enrollment planning.
Mm-hmm.
From an operational point of view, is there a plan that at the -4 to -1 screening visits, when we determine that a patient is eligible, will there be an enrollment verification form that we send to Will or to you guys, and then we get authorization to enroll into a cohort? How's it going to be operationalized? Otherwise, you're going to have a...
So great question. I'm in operations, so I love those kind of questions. Thank you. For now, what the plan is that there will be to give Will a call. So Will wants you all to call him and have those discussions. Certainly an enrollment approval form is something we can look at, but I think, we're not a huge group here. And Will likes to have that personal conversation with the patient. So what we're asking is that your site give Will a call and discuss your potential patient before you screen. Does that make sense?
So this question is actually during the screening.
Oh, during the screening. Okay.
We're doing all the screenings. We're checking the eligibility. And once we actually confirm that the PI confirms the eligibility.
Yes.
Do we then give Will a call as well, or will there be a form we can send or something? Because
I make fun of him that he wants everyone to call him all the time. But yeah, absolutely. So there is a checkpoint, and the checkpoint is in EDC. So after you've completed all screening procedures and you've determined the subject is eligible, you will go into EDC and you'll click, yes, this patient is ready to be randomized. You'll click the button. It'll send a trigger to Will, and you won't be able to actually randomize the patient in the IRT system until Will has gone into EDC and approved. So it's going to be managed through the EDC system. So you'll go in, you'll click, yes, this patient's ready to be randomized. Yes, Will get an email. He'll go right away and review the data that you've already entered in EDC, so make sure you enter the data. And then he'll click approve or not approve, and you'll get a trigger back saying, yep, go for it. And then IRT will allow you to dispense drug.
Just a question about the vital signs. Given that you're thinking that Cmax is at 24 to 48 hours post-dose, is it worth doing vitals at the times that you draw those PKs as well at 24 and 48 hours?
It's not mandated in the protocol, but I would look to my colleagues to, is that something that you would suggest, doing vitals at those extended PK timelines?
For the first visit, yes, I would anticipate that, I don't think you need to do orthostatics, but I think that if a kid's coming in, it's probably standard just to get basic vitals. As far as in future, I would only say it would be sort of standard of care if a kid's having issues that make you think that maybe they're having blood pressure changes. Of course, you would go through the whole rigmarole and do orthostatics. But yeah, in the visit 1, the PK visits, I would love to see vital signs.
So that data won't have to be entered in EDC because it's not required by the protocol. But what it sounds like is that it's a very good idea.
But just from a safety perspective, if I have a kid in my office, I'm giving a shot, I'm going to do it anyway as standard of care, that's the reason it's not.